Now we'll start our roundtable 30 under the title of Atypical Benign Paroxysmal Positional Vertigo. The chairperson is Dr. Mohammed Mustafa Abdel Tawab, Dr. Mustafa Yusuf, and the moderator is Professor Dr. Samir Asal, and with the speaker, my colleague, Dr. Mustafa.
Okay, we will start with Dr. Enis Elpin Generi, and he will talk about horizontal canal BPPV. Dr. Enis.
Good morning. Mr. Chairman, Mr. Moderator, thank you for your kind invitation and also for the organizing committee. I will talk about horizontal canal BPPV, which accounts for almost 25% of all BPPV cases. So it's not rare because the mechanisms are well understood nowadays, and the cases are referred to tertiary centers where most of the publications are made. It's open, but yeah, okay. In order to understand horizontal BPPV, we shall know those two facts in the first place. The first one is the horizontal canal is not in the horizontal plane. It's inclined 30 degrees upwards, we'll see later, and we shall always remember the second law of Ewald. Let's see the horizontal canal. It makes a 30-degree angle with the Frankfurt horizontal plane, so it's not horizontal. And according to the Ewald's law, the kinocilium is oriented towards the ampulla. So the flow of envelope towards the ampulla, let's say the ampulla pedal, causes an excitation in the firing rate, in the basal firing rate. So this is an exterior flow, and the resulting fast phase is towards the stimulated ear. In order to understand the mechanisms of horizontal BPPV, we recently made a publication. You can download this from the internet, and also you can print out this model. You can mount this model in the head of a patient and simulate the gravity-induced movements of the otoliths in order to understand the pathophysiologic mechanisms better. The test of horizontal canal BPPV is the roll test, which is named after Pagnini and McClure. We simply put the head in 30-degree elevation form and switch sides between left and right. We shall notice two kinds of nystagmus. The first one is geotrophic, which means towards the ground. This is the most common form. And the other one is apogeotrophic, which means towards the sky. Okay? And these are always horizontal, no rotatory components, because the horizontal canal is connected to medial and lateral rectus muscles. I personally know more than 8 forms of horizontal canal BPPV. The most common one is the horizontal long arm canal lithiasis, in which the particles are located in the long arm. And the second one is cupular lithiasis, and the particles may be attached on the utricular side, rarely. Light cupula is a rather controversial phenomenon, but we may sometimes notice it. And the other ones are short-term canal lithiasis, in which the particles may be on the canalicular side or the utricular side, and we may see ipsicanal conversions, I mean geotropic to apotropic form, or vice versa. And rarely, canal jam may occur after maneuvers. In order to manage those cases, we have to do the roll test in every positional vertigo patient and try to define the mechanisms and decide which ear is sick and define the atypical cases and choose the appropriate maneuver and set up a follow-up schedule by eliminating risk factors. Now, you see, we turn the head to the left side, and the first phase of the nystagmus is towards the left. And this is geotrophic. And when we turn the head to the right side, we notice that it's geotrophic on the right side, but it's faster. So in almost every cases, there is a side that the nystagmus is faster than the other side. We have to take care of this. When we see the geotrophic nystagmus, we have to decide on which side it is more strong. In the most common form of geotrophic horizontal canal BPPV, in which the particles are located, when the patient lies on the sick side, the movement of the otoliths causes an excitatory stimulus, and the nystagmus is towards the sick side. And this is the strongest side. And when the head is rotated to the other side, in which case the sick ear is upwards, the flow of endolum causes an inhibitory flow, which makes the eye have a slower geotrophic nystagmus. So we can decide, according to the Evil's law, which side is sick. And this is an example of apogeotrophic nystagmus. The head is switched to the right side, but the nystagmus is towards the left side. This is apogeotrophic. Okay? And when we roll the head to the other side, you see it's rather fast. And remember that the slowest side, the weaker side, is the sick side in apogeotrophic cases. So we didn't do the roll test to the left, but most probably, since this is a strong side, most probably the left ear is sick. We can decide by looking at the fast apogeotrophic nystagmus, because it's not probable that the other side may show a more strong nystagmus than that. Then, switching to the left side, left roll, you see this is also apogeotrophic towards the right side, but it's weaker. So the left side is sick. And the mechanism may be cupular lithiasis or short arm canal lithiasis. Yes, this is cupular lithiasis. Rarely the particles may be attached on utricle side, and we cannot understand on which side the particles are attached by simply doing this. I will mention short arm canal lithiasis, in which the particles are located on the canalicular side or the utricle side, but they are not attached to the cupula. This may also cause apogeotrophic nystagmus. Conversion and canalicular jam, the other rare two mechanisms. Let's consider cupular lithiasis. When we turn the head to the sick side, the flow of endolum is inhibitory. So we'll have an apogeotrophic nystagmus.
2 minutes left. 2 minutes.
Yes, okay. So I will mention my last slides. I don't have time to talk about repositioning maneuvers, but please do not forget that if you see a temporary nystagmus, you are facing with canal lithiasis. But if the nystagmus is persistent, I mean with no latency and long duration, you have to consider cupulopathy, mostly cupular lithiasis or rarely light cupula. So I thank you for your attention and for your patience.
Now we will move forward for the next speaker with Dr. Pulent. The title is Atypical Benign Paroxysmal Positional Vertigo. Can we start?
colleagues, good morning. First of all, I would like to thank Professor Fabian. For the kind invitation here. My topic is the atypical BPPV. Atypical BPPV is defined as all BPPV types and related to nystagmus other than classical posterior canal BPPV, anterior canal BPPV, and horizontal canal BPPV. When we encounter a patient with a BPPV and classical BPPV, we mostly easily handle with the patient with several maneuvers. However, when we encounter atypical nystagmus, we always think about whether it is a central lesion or atypical BPPV. In the literature, atypical variants of BPPV is grouped like this: direction fixed positional nystagmus, posterior canal apogeotropic nystagmus, sitting up vertigo, subjective BPPV or Yetişer variant, or short-arm canal lithiasis, even spontaneous nystagmus, heavy and light cupula. Ototic debris can be located in several sides of the cupula and several parts of the semicircular canals that can cause atypical BPPV. Among the atypical nystagmus, direction fixed position nystagmus is described by Califano et al. It is characterized by directionally constant positional nystagmus. This condition causes typical BPPV symptoms and presence of paroxysmal horizontal unidirectional positional nystagmus in supine roll test that is apogeotropic on the affected side and geotropic on the healthy side. It is the rarest form of the horizontal canal BPPV. Pathogenesis is still unclear, but the mechanism is the canal lithiasis rather than cupular lithiasis, since the conversion to a classical geotropic form always occurs in the reported case. Now, in the picture, I will describe the mechanism of the nystagmus. Free-floating otoliths in both ampullary and non-ampullary arm of the horizontal canal are the main cause. As seen on the left side of the panel, initially otoliths are located near the lobus part of the non-ampullary arm of the canal, and when the patient lies on the affected side, ampulofugal flow occurs due to presence of otoliths in the ampullary arm, resulting in an apogeotropic nystagmus. As seen on the right side of the picture, ampulofugal flow, geotropic nystagmus appears when the head is rotated to the opposite side. Posterior canal apogeotropic BPPV is described by Vanucci et al. In 2012. Free particles stand near the distal part of the non-ampullary arm of the posterior canal. Suspicion arises if the AC repositioning maneuvers do not improve the symptoms, or if the subsequent testing reveals a typical posterior canal BPPV nystagmus. Sitting up vertigo is another atypical variant. It is a clinical picture of upbeat nystagmus and positional vertigo that occurs while the patient is sitting. Mechanism is explained with anatomic restriction of otoconal debris in distal moment in posterior canal or particles on the reticular side while lying down during the Dick-Salpike test. This syndrome is seen more commonly early after the repositioning maneuver of posterior canal BPPV, but it has also been reported to occur weeks after the maneuver. Skopko et al. Also focused on stick-up vertigo. They proposed this antibody would be produced by a nerve canal when the patient assumed the dick-sulfide position, which would prevent the movement of particles near the cupula. But when seated, it would first cause an ampullary pedal flow because of the inertia that would not develop in nystagmus or may go unnoticed, and then a more intense ampulofugal flow because of the gravitational forces that would develop into a apitic nystagmus with a torsional component through the ampulofugal movement. Actually, this antibody was mentioned first, Buki et al. They said there were patients in whom, despite the typical complaints of BPPV and with no positional nystagmus, they called subjective BPPV or type 2 BPPV. Sometimes they noticed abnormal retropulsion of the trunk while sitting up. Authors concluded it might be the result of the chronic canalolithiasis within the short arm of posterior canal. I will skip on some of the variants in theoretical meaning. I will go through some of our cases. This patient was a 26-year-old female. She was a physician. She had a BPPV history in the past, and several maneuvers were applied. And then she still described vertigo. In the right dick-sulfide test showed tiny right torsional nystagmus between the 14 and 25 seconds, and she felt vertigo. Very tiny upbeating, right torsional, and reverse nystagmus not observed. And right apnea maneuver was performed. Next time, left dick-sulfide test showed 3-degree upbeating left torsional nystagmus. Very tiny 3-degree. And then left apnea maneuver was applied. 1 week later, both dick-sulfide tests in both sides showed minimal torsional nystagmus, but she described more intense vertigo. Then we decided on proceeding with the bow and lean maneuver. In this test, downbeating nystagmus of 10 degree was observed in both tests. No nystagmus was observed in lean test. And right and left semo maneuvers were performed 1 day apart.
2 minutes left.
1 day later, no nystagmus was observed in dick-sulfide test. However, downbeating of 4 degree nystagmus in the both test was noticed, and the patient did not feel vertigo and no further maneuver was performed. This nystagmus is still going on, and we noticed in the literature Ko and et al. Focused on this issue, vertical nystagmus in the bow and lean test that may show the hidden posterior canal BPPV. This is the mechanism of nystagmus appearance in bow and lean test for a hidden posterior canal BPPV. This case, 45-year-old female, She had a severe positional vertigo. In the right supine roll test, initially right beating, nystagmus of 34 degree, continued for 30 seconds, then changed the direction beating to the left. That means apogeotropic. Change the direction. In the left supine roll test, left beating nystagmus of 24 degree, continued for 85 seconds. Right horizontal canal canalitis BPP was diagnosed because the nystagmus was more intense when the head was on the right side, and barbecue maneuver towards the left side performed, and no nystagmus was observed in the control. Right horizontal canal canalitis BPPV was diagnosed when we show nystagmus reversal in the same position in this variation. And literature also proposed that short-term war adaptation may explain this condition. Dear Chairman,
Time.
this time is complete.
Okay.
Thank you very much for your attention. I had actually another case, but time limitation. Thank you.
Now our next speaker, Professor Dr. Samir Asal, and he will talk about secondary signs of lateralizations of lateral canal BPPV. تفضل دكتور سمير.
بسم الله الرحمن الرحيم. Good morning everybody. My talk today about the secondary sign of lateralization of lateral canal. The problem in diagnosis of lateral canal is to decide which side is affected. In most of the case, we depend on the AWL second row, which indicates that the nystagmus resulting from excitation is greater than the nystagmus resulting from inhibition. So in geotropic form, the affected side is the strong side, and in apogeotropic form, the affected side is the weak side. But in some cases, the difference between both sides in tendency may be difficult, especially in apogeotropic cases. So in these cases, we need some sign to decide which side is affected. So which is called secondary sign of lateralization. We have a 5 sign, 3 sign while the patient is sitting, and 2 sign while the patient is supine. While the patient is sitting is a pseudospontaneous nystagmus, Boindeli nystagmus, and head shaking induced nystagmus. While the patient is in supine position, it is a sitting supine nystagmus and null point in yaw plan. The pseudospontaneous nystagmus, it is a horizontal nystagmus present in a patient with lateral canal BPV in a sitting position without unilateral vestibulopathy. It is variable in most of the cases, ranging from 40% up to 90% of the cases, but it helps in diagnosis which side is affected. In geotropic form, the nystagmus is beating toward an affected side, while in apogeotropic form, the nystagmus is beating toward the affected side. The idea behind this pseudospontaneous nystagmus, as you know, that the lateral canal is directed downward and backward 30 degrees from the horizontal plane. So in sitting position, the otoconia, which has a weight, which is specific gravity greater than the endolymph, it moves under the effect of gravity. In geotropic form, it moves away from the utricle, and in apogeotropic form, the anterior canal, it moves towards the utricle. So the pseudospontaneous nystagmus beating toward affected side in apogeotropic form and toward unaffected side in geotropic form. So, but the question, how to differentiate between pseudospontaneous nystagmus and the true spontaneous nystagmus, which indicate unilateral vestibulopathy, by what's called head pitch test. In head pitch test, while the patient is sitting position, the lateral canal directed downward, backward 30 degrees, so the otoconia move under the effect of the gravity. When the patient ventroflexes the head 30 degrees, the lateral canal become in the horizontal plane, so the otoconia stop moving, so the nystagmus will disappear. When the patient ventroflexes the head 60 degrees, so the movement of the otoconia move in the opposite direction, so the nystagmus reverse its direction. This is not occur in a case of true spontaneous nystagmus. This is a case that has a lateral canal and has pseudo-spontaneous nystagmus. While sitting position, it has left beating, direction fixed, spontaneous nystagmus. So before deciding this is a true spontaneous nystagmus, we must do a head pitch test to decide is it true or pseudo-spontaneous nystagmus. So when the head ventroflexes 30 degrees, the nystagmus disappear. So the osteoconia stop moving. This is not occur in a case of true spontaneous. When ventroflex is 60 degree, the direction of the canal is reversed, so the direction of the osteoconia movement is reversed, and the nystagmus reverse its directions. And when returned back to the setting and hyperextend the neck, the nystagmus reappear again in the original direction, but with high intensity. So the nystagmus will reappear again, the left beating but strong intensity. So احنا بنستفاد في السودو سبونتينيوس ان انا بقدر احدد which side is affected. If the case is geotropic, so it is directed toward unaffected side. If it is epigeotropic, it is directed toward affected side. The second sign, it is a Bois-en-Delin nystagmus. If the patient don't have a pseudo-spontaneous nystagmus, we will search for it by what's called Bois-en-Delin. The same idea, like pseudo-spontaneous nystagmus, it is the idea of Bois-en-Delin nystagmus. While the patient is ventroflexes the neck 60 degree downward, the otoconia move in the direction of utricle in a case of geotropic form, and in opposite direction in the epigeotropic form. And when the patient hyperextend in lean direction, the reverse occur. So we search for Bois-en-Delin if we don't have pseudo-spontaneous nystagmus. Take this patient as example for all secondary signs that will present in this direction in supine roll test. For this patient in right position, give right beating, direction fixed in nystagmus. And on the left side, give a strong left beating nystagmus. So this case is by Bois-en-Delin, by Ewald-Delot. It is a left geotropic lateral canal BPPV canalisis. So remember the cases and we'll apply all secondary sign on this side. This patient has a left lateral canal BPPV canalisis. So let us to see Bois-en-Delin in this patient. For Bois-en-Delin, because he is geotropic, the bone nystagmus will be toward affected side. And for the nystagmus, it will be toward unaffected side. So for the same patient, in this Bo position, he has a left lateral canal. So the Bo nystagmus will give a left beating Bo nystagmus. So the Bo is beating toward the affected side because it is geotropic form. And in the lean, the patient give a right beating nystagmus beating toward unaffected side. طيب السؤال هنا هل احنا من البوأن-ديلين نystagmus بس without supine roll test نقدر نحدد which side is affected and which pathology، هل هي geotropic ولا epigeotropic، وهل which side، هل هو right ولا left، ولا لازم نستعين بالسوباين رول تيست؟ انتوا ايه رايكم؟ يعني لازم نعمل سوباين رول ولا يكفي البوأن-ديلين بس؟ لا، ممكن من البوأن-ديلين بس نعرف من غير السوباين رول نعرف which side affected وهل هي geotropic ولا epigeotropic. لو قلنا عندنا ايوالد-دلوت بيقول ان الاكسيتيشن is greater than inhibition. في الحاله دي مثلا اللي تحت في البو it is greater than the lean. So the excitation in the bow خلاص and the inhibition in the lean. So this case is geotropic. which side affected هنبص على اتجاه الجيوتروبيك عن اتجاه البون nystagmus. هو left يبقى دي left lateral canal canalisis. The third sign while the patient is sitting it is a heat shaking induced nystagmus. Whatever the patient is geotropic or epigeotropic, the heat shaking nystagmus will be toward unaffected side whether it is geotropic or epigeotropic. دي سهله للجميع ممكن ايه نعملها. خلينا نفتكر العيان بتاعنا، احنا قلنا العيان ده عنده ليفت لاترال كانال جيوتروبيك BPPV. نعمل له بقى الايه الهيت شيكنج. So whether the patient is geotropic or epigeotropic, the nystagmus will be toward unaffected side. طب احنا بنلجا للسكندري ساين ديت لو احنا الايوالد-دلوت ما حليناش المشكله. So nystagmus beating toward right. So this patient has a left. Okay. The fourth sign it is a sitting supine position. Sitting supine position while taking the patient from sitting position while the head in straightforward position to supine position. This is will be a sitting supine nystagmus. Sitting supine nystagmus it is beating toward unaffected side if it is geotropic, and beating toward affected side if it is apogeotropic like the lean nystagmus. عندنا ثلاثه شبه بعض، اللين والسيتنج سوباين.
One minute left.
طيب يا كابتن
2 minutes left.
السودوسبوتينيس. طيب تعالى نشوفه كده، اللي هي العيان بتاعنا دوت اللي هو عنده ليفت لاترال، هنعمل له سيتنج سوباين. It has a left lateral geotropic, so the nystagmus will be toward an affected side. Give a right beating sitting supine nystagmus, so the affected side is a left. Okay. آخر sign عشان مصطفى ما يزعلش. It is a null point in horizontal plane. Null point it is مين النال بوينت موجوده في كذا نوع من النستاجمس، زي بالظبط كده الكونجينيتال نستاجمس عندنا نال بوينت، عندنا في اللايت والهيفي كيوبلي عندنا نال بوينت. نال بوينت it is a certain point at which nystagmus disappear. In the case of lateral canal the nystagmus disappear on the side with strongest nystagmus, then for few then appear again in the opposite direction. لو الحكايه دي حصلت في ناحيه من ناحيات السوباين رول this indicate دي الناحيه الاقوى. ما دام هي النحو الاقوى انا كده اعرف احدد which side affected. لو انا جيوتروبيك يبقى this is affected side. لو هي ايبوجيوتروبيك so it is an affected side. So the null point occur in the side with the strongest nystagmus. وانا الهدف عاوز اعرف مين السترونج ومين الويك. تعال نشوف برضه على نفس العيان بتاعنا اللي هو عنده ليفت لاترال كانال جيوتروبيك. هو كده سوباين رول اهوت، وديت رايت سوباين رول جيف رايت بيتنج جيوتروبيك نستاجمس. هنستنى خالص لحد لما النستاجمس يختفي ونشوف هل هيعكس ولا لا. هو العين ده ليفت، عشان بس نجري الفيديو عشان الوقت. هنا على الناحيه الليفت اهو جيف ليفت بيتنج سترونج دايركشن فيكسد جيوتروبيك نستاجمس. نشوف بقى لما النستاجمس ده هيختفي هيحصل ايه. يعني سبوز اللي احنا مش عارفين وش سايد از افكتد، الاثنين سوا بعض. هنا النستاجمس بدا يختفي اهو خالص، هنستنى لما يختفي، نستنى كده كام ثانيه ونشوف هيحصل ايه. هو كريسيندو ديكريسيندو لحد ما يختفي خالص، هو كده اختفى. تمام. هل هيعكس ولا لو عكس اتجاهه يبقى ده سيزونال بوينت. شايفين بدا يعكس اتجاهه اهوت بقى رايت بيتنج nystagmus. So this is a null point of nystagmus which occur in the side of strongest nystagmus. Okay. Again, we have a 5 sign for secondary sign of lateralization. 3 while the patient is sitting, pseudo-spontaneous, Boandeline, head-shaking nystagmus, and while the patient is supine, it is a sitting supine nystagmus and a null point in horizontal plane.
Okay, thank you, Dr. Samir, and thank you to our all speakers and audience, and to the next setting.
Next session.